My name is Juliette Chami. No matter how my name will read there, you'll have to trust me on that one. And I'm a population health scientist. I lead a research group at the University of Oxford within the Big Data Institute in the Nuffield Department of Population Health. And I am interested in improving the treatment of neglected tropical diseases. Neglected tropical diseases affect over 1 billion people worldwide. We've heard this already today. And that's just the bare minimum. Most people are affected by one or more neglected tropical diseases. And these individuals mainly live in rural, poor areas of low-income countries. And the infections persist predominantly because of the lack of access to safe water and adequate sanitation. Don't let these cartoons fool you. These diseases cause serious harm, and if they're left untreated, can have long-term impacts that reduce cognitive development, reduce educational attainment, and impair work productivity. The most common of these diseases are caused by parasitic worms, some of which you may have heard of: elephantiasis, river blindness, gut worms from Deworm the Children campaigns, and a disease that I'm particularly interested in, which is schistosomiasis, which is also called snail fever. We've really only had one main treatment strategy for these parasitic worms, and that's mass drug administration. Mass drug administration has been implemented for decades. And the way that it works is that you identify an at-risk area and you treat everyone. It's a blanket treatment, there's no diagnoses, you give single-dose oral preventive chemotherapies to everyone you assume to be at risk, whether they're infected or not. And these huge programs treat 1 billion people a year. And this is a key example of where we were talking about the role of pharmaceutical companies, where pharma is the good guy. Pharmaceutical companies like GSK or Merck, for example, donate millions of dosage forms each year that mainly go to the WHO. Then the endemic countries can apply for these medicines and combine them with international aid, predominantly from the UK and the US, to run mass drug administration programs. When they finally reach the communities on the ground, they're using volunteers. These are either primary school teachers that are treating enrolled children, or they're volunteers like community medicine distributors within the local villages that are responsible for moving from home to home or setting up a central point to treat everyone within their village. But if we're going to start thinking about more ambitious plans of reducing the prevalence of a disease to zero or eliminating a pathogen, then we need more than mass drug administration. And the first place that we can start is by recognizing that communities are not homogeneous. So even though we might apply one strategy, intra-community variation is evident. And here are some simple examples. With medicine efficacy, this varies widely by individual, and it will be determined by their age, their metabolism, their infection history. And for some of the diseases that we treat, like schistosomiasis, we only have one drug that we've been giving out as a blanket treatment since the 80s. So we need to ensure that we're effectively using that treatment. Your infection risks will be determined by local ecology, and also by your lifestyle, which occupation you have. Smallholder farmers will be more at risk of hookworm, whereas fishermen will be more at risk of schistosomiasis. Even your placement within your village social network, if we were to take all your friendship connections and graph them in a village, even your popularity will determine how likely it is that you are even going to be offered medicines in these campaigns, even though the medicines are provided at no cost. And then, of course, most importantly, the onset and progression of disease is determined by your individual biological, social, and economic factors. So in very close collaboration with the Ugandan Ministry of Health, we're trying to take into account these individual characteristics and move towards more tailored treatment strategies. This is not a new idea whatsoever. In high-income countries where we have electronic medical records, precision medicine is rapidly advancing. We are just trying to take this concept and adapt it to rural poor communities where there are not electronic medical records. And to do this, we focus on 4 key components. One is scale. We try to collect data that's interoperable, consistent, and computable. We do that by training local villagers who may only have had a primary school education to collect data in real time. You can find great scientific capacity wherever you're working. And we constantly ask the question of when is big data needed? There are some questions where you do not need millions of observations to answer. And then, of course, we're conducting some large-scale studies to inform these massive programs, these massive treatment programs. We have a study ongoing in Uganda of over 20,000 people, and we're looking to scale that to over 100 to 150,000, where we've collected almost every imaginable type of data on this population. And then when you deal with big data, something really important to consider is big data is not just about numbers, it's about dimensions. How many characteristics can you measure for a person so that you can customize treatment or tailor treatment? But the more dimensions that you gather, the harder it is to handle that data. So we're working to develop methods either through machine learning and combining local knowledge to inform how we can handle complex data. And then overall, the last thing I would like to finish with is the most important component of doing this sort of work and progressing towards tailored treatment strategies is building local scientific capacity, training master's students, PhDs, and postdocs, not only individuals within the local communities, to be leaders within their own countries. They should be leading the questions. They are the ones that are going to enable good research, good quality data collection, and that's really what I think should be the focus of doing this sort of research. I'm just one person. They're an amazing team that without this sort of collaboration, none of this innovating work could be possible. So thank you.